Welcome to Health Yeah, where experts from Stony Brook Medicine come together to discuss topics ranging from the complex inner workings of an infectious disease to tips and tricks for staying safe and healthy all year long.
Welcome to Health Yeah, where we break down the health topics that matter most to families. I'm Catherine Kier, Pediatric Pulmonology Division Chief, and today we're shining a light to one of the most overlooked issues in pediatric health: children's sleep. Sleep plays a powerful role in behavior, learning, growth, and emotional well-being. Yet, many families underestimate sleep problems or don't recognize the signs when they appear. So I'm joined by two of my colleagues, a wonderful combination: pediatric sleep specialist Dr. Matthew Ednick and Dr. Jamie Doody, an otolaryngologist. Dr. Ednick, can you please introduce yourself?
Yes, thank you, Dr. Kia. So my name is Matthew Ednick. I'm an attending physician here at Stony Brook. I work for the Children's Hospital in the Division of Pediatric Pulmonary and Sleep Medicine, and I see a multitude of patients with respiratory concerns and issues like cough, wheezing, asthma, cystic fibrosis. But I also see a multitude of kids with multiple sleep disorders, including insomnia, sleep apnea, things like that.
Thank you, Dr. Ednick. Dr. Doody?
My name is Dr. Jamie Patrick Doody. I am a pediatric ear, nose, and throat surgeon here at Stony Brook. I completed my training through the Royal College of Surgeons in Ireland before completing fellowship in Boston Children's Hospital. I worked in Chapel Hill and UNC for a while, and I'm here at Stony Brook for 2 years. I treat the full gamut of pediatric ENT disease, such things as airway disorders, benign and malignant tumors of the head and neck area, but also pediatric sleep is also within my remit of treatment of patients here.
Fantastic. Happy to have both of you at Stony Brook and again here at the podcast. So let's start the question. So let's explore. We know that there's a lot of concerns for parents about sleep. So Dr. Ednick, tell us about what good sleep would be for children.
So good sleep varies amongst all kids, and not every kid fits in one box. First thing we always talk about is total amount of sleep. And like I said, that can certainly vary with child and with age. The rule of thumb I like to think is kids in that 3 to 6 year old range generally need anywhere between 9 and 13 hours of sleep. Obviously, the younger they are, the more sleep they need. The older they are, the less sleep they need. But always very important to discuss with families, parents, as well as kids, is proper sleep hygiene and consistent bedtime routines.
So when would parents start, have concerns about their kids' sleep?
So parents can have concerns about their child's sleep at any time. And if there's any concern about their sleep, we certainly recommend that they speak to their pediatrician, who then can refer accordingly to a pediatric specialist.
Can you tell us examples of what parents should watch out for?
Yeah, so there's lots of things. One of the most common things we see is just trouble going to sleep, trouble falling asleep. And that falls under the umbrella of insomnia, but it could also be trouble staying asleep and different things that exist during the sleep, whether it's snoring or any sort of breathing abnormality. Are you concerned with how they look when they're sleeping? Are they having what they would consider abnormal behaviors during sleep? Are they staying in bed? Or are they getting up? Are they having trouble waking up in the morning? Things like that. And very important, especially in young kids who go to school, are they able to function at a level that they should be during the day at school?
So when would parents or pediatricians refer to you?
Yeah, so we certainly get a lot of referrals from community providers as well as other providers in the hospital. The most common reason we see kids in the pediatric sleep center here is usually kids that snore and or have big tonsils. With the snoring and with the big tonsils, like I said, we certainly get into more detail about the sleep, but that's certainly one of the more common complaints. But like I said, we definitely see lots of kids who have trouble falling asleep at night, trouble staying asleep at night. And just like I said, if the parent has concern about anything related to sleep, we are certainly happy to see those patients.
Yeah, so I'll turn to Dr. Duty. Dr. Ednick mentioned about tonsils and adenoids. How do you see these patients? I know that we have partnerships and refer to you, but where are these patients coming from?
So these patients are primarily coming from their pediatrician. As Matt alluded to, the history is common that they present with snoring, and it's usually of a significant amount to cause concern at home. And then the child presents to the pediatrician and they perform an exam and they see that they have enlarged tonsils. They also might display other behaviors such as open mouth posture when they're sleeping, which could be indicative of adenoidal hypertrophy. The adenoids are a lymphoid tissue behind the nose, above the uvula. Or punching bag, and that can cause nasal obstruction, and that can create snoring as well. So patients present in a myriad of ways, but it tends to be snoring is the most common one, and I do get them from pediatricians a lot.
So parents become concerned about seeing you because, their next would be surgery. So tell us how you evaluate these kids and when is surgery really a decision?
I think in days gone by, I think, surgery was performed kind of more blindly or empirically in patients that presented with these symptoms. But with the advent of technology and better understanding of sleep and the technologies behind sleep studies, I find that informs my decision making more and more, because oftentimes the clinical picture does not correlate with presenting symptoms and vice versa. The classic image of a person with an increased body mass snoring heavily can have quite a low obstructive index, whereas a very low body weight child was quietly snoring can have a very high. So the sleep study is a key element of helping me make my decision, because not everyone needs surgery. Okay, if we do the sleep study and we see that they have significant sleep apnea, then surgery is something that we can certainly discuss and would be recommended by me.
So you mentioned about sleep study. Dr. Ednick, what is a sleep study?
Yeah, so a sleep study is a test that we do in our sleep lab where we assess patients, again, in our case, children, overnight. Generally what happens is they come with a parent to the sleep center. They usually get there around evening time, 7:30. They have their own room, separate beds in that room, but they have their own room, one for the parent, one for the patient. And we have overnight sleep technologists that come in and they basically hook up the kid. Nothing that hurts, and I always make sure to tell the child that, make sure to tell the parent that nothing hurts. But it's sensors generally on the head, the face, and the body. And everything we're doing overnight is to assess their sleep, is to assess their breathing during sleep. But we also assess other things. We assess oxygen levels. We assess carbon dioxide levels. We look for any sort of abnormal limb movement behavior. And we, again, in evaluating their sleep, we're looking at their brain activity to see if there's any abnormalities in their brain activity. We check basic EKG monitoring, which is heart monitoring. So we're not just checking the breathing, which is usually the most common thing we're checking for. We're checking a whole host of other things. And just jumping on what Dr. Didi was saying just before, no matter how much you complain or how many symptoms your child has prior to doing a sleep study, no one can with 100% certainty say you have sleep apnea or you do not have sleep apnea. You need a sleep study to show that you do or you don't.
That's why that collaboration is important.
Yes, 100%.
So tell us what the surgery is.
Yep. So the first line surgery in otherwise well children that have obstructive sleep apnea, the recommendation is to perform a adenotonsillar surgery. Okay. Classically, it would be removal of the tonsils, tonsillectomy, and removal of the adenoids, adenoidectomy. It's a 30 to 45-minute procedure. It's a full anesthetic. If a child is actually very well and their sleep apnea is on the kind of moderate or mild end of the spectrum, it can be safely performed as day surgery. If it's more severe or the child has another comorbidity or illness, it would be performed as an overnight surgery. The recovery period is 2 weeks at home with very limited activity. And the risks involved are, you do have a sore throat. We can't avoid that, but we do manage it very well with non-opioid analgesia. soft diet because, they're sore back there, and eating sun chips would probably be a terrible idea. So we recommend soft, mushy things like, overcooked mac and cheese, soups, stews, pudding, ice cream, delicious things that we can have.
Lots of ice cream, right?
Lots of ice cream, just to make it a little bit better. And then the dreaded side effect, complication would be the small risk of bleeding. It's approximately 3% with tonsillectomy, bleeding from the nose or mouth, that can occur within the first 10 to 14 days after surgery. They do require to be reassessed by a medical professional. We usually recommend coming back to the emergency department. But 80% of these do spontaneously stop on their own without any further intervention. A small percentage of the overall people who have tonsillectomy done do require a means or another procedure to stop the bleeding if it does continue. But overall, the bleeding rate is approximately 3%, and of those, about 80% stop on their own with no intervention required.
That's good to know. That addresses a lot of the concern and angst of patients. Dr. Ednick, any other management for sleep problems in children?
Yeah, so especially in kids that have sleep apnea, that have big adenoids, that have big tonsils, the first line treatment is always going to be to send to Dr. Duty to talk about the tonsillectomy and the adenoidectomy. For very mild kids, there are a few less invasive management therapies we can use. Sometimes we use a simple nasal steroid spray, which helps reduce any inflammation that might be in the nose or the back of the throat. But the ultimate treatment, if there's no surgical options and it does require more definitive treatment than just a nasal spray, would be what's called CPAP. CPAP is continuous positive airway pressure. It's usually the first line therapy in adults for sleep apnea. And people sometimes think of CPAP as the mask or the machine that is required when you sleep at night. And again, it's a mask that's hooked up to a machine. And again, it's continuous positive airway pressure. So it's blowing a pressure of air to keep that upper airway open. It's not oxygen. It's simply a pressure that keeps that upper airway open. And CPAP has been shown to be very effective in patients with sleep apnea. The biggest thing that concerns us as providers is often adherence or compliance with the CPAP, because CPAP is generally recommended and required during all sleep periods to treat the sleep apnea.
So what are the challenges and how do we support parents with the kid using the CPAP?
Yeah, so like I said, especially in young kids, we explore all other treatment options before we go to the CPAP. But in terms of supporting both the child and the family, we have to obviously encourage them that there's no other treatment option and that CPAP is the best thing for long-term health. Again, ensuring that they have a mask that fits them appropriately, a mask that fits them comfortably. And like I said, the most important thing with CPAP adherence is frequent follow-ups and education. So kids and young adults that we start on CPAP, oftentimes I'll be seeing them on a pretty frequent basis, maybe every couple of weeks, every month, just to ensure that they're adhering to the CPAP and we're addressing all their concerns, making sure the pressure is heated and humidified, because that definitely is more comfortable to the patient when they're receiving that pressure.
That's really good for parents to know.
Yeah, I think so.
So let's talk about sleep problems that's not related to snoring or sleep apnea, which is the more common things that we see. How about healthy sleep habits? That's, again, a good discussion for us.
Most importantly, especially at bedtime, is proper sleep hygiene. Good and consistent bedtime routine. So what does that include? So any extracurricular activities, exercise, things like that, we definitely want to be done earlier in the evening. But once they kind of decide it's getting closer to bedtime, proper sleep hygiene. So no stimulating activities for at least 30 to 60 minutes before. Lots of times we like a little more cooler environments as opposed to too hot. Like I said, consistent routines each and every day. And most importantly, especially these days, is the avoidance of electronics for at least 30 to 60 minutes before they actually put their child to sleep. And electronics, there's a lot of electronics out there. So it's not just the phone, but it's the phone, it's the computer, it's the TV, it's the tablet, it's the watch, it's the gaming system, it's whatever you want it to be. We certainly recommend the avoidance of all those electronics at least 30 to 60 minutes before bedtime.
Yeah, that's a very good point. So, does poor sleep mimic ADHD, like a hyperactive kid?
Yeah, so I mean, you certainly know. We see a lot of we don't just see the snoring kids in clinic, in the office, but we see plenty of kids that are either getting worked up for or have a diagnosis of ADHD, attention deficit hyperactivity disorder. And the reason is because poor sleep, not good sleep, insufficient sleep, not enough sleep, can certainly present with behaviors that mimic ADHD. And what's most important in the kids that we're seeing is they have to be able to get up for school, go to school, pay attention in school, stay focused. And when they don't get good sleep at night, whether it's due to sleep apnea, whether it's due to sleep deprivation or not enough sleep at night, the kids are quote unquote overtired, where they can have poor attention skills, poor focus, hyperactivity, things like that. And certainly those things need to be addressed with the hopes that improving the sleep will improve the daytime activity. And then we could either minimize or potentially avoid a diagnosis of ADHD, which again lends itself to over treatment with medications for ADHD, when in reality it may be just be related to poor sleep habits.
Dr. Ednick, I have a question about healthy weight and sleep. So what is the connection about kids with increased body mass index or are, heavy and sleep?
Yeah. So obesity obviously can affect your overall health, not just in kids, but adults as well. And patients who are obese or have an elevated body mass index certainly increases the likelihood of having obstructive sleep apnea, because again, it's not just extra tissue in their belly and their arms and their legs, but certainly in the neck area and in the back of the throat as well. In patients we always are recommending healthy diet, regular exercise, and things like that. And just along the lines of what Dr. Doody has been touching on in terms of surgical treatment for obstructive sleep apnea, patients with elevated BMIs or obese, the curative rate of surgery is going to be less in a patient that's obese as compared to a child that's not obese.
Yeah, that's really important for us to emphasize because, as we mentioned, really sleep affects not just behavior, but overall health.
Yeah, and just again, touching on obesity, sleep deprivation or not getting enough sleep can certainly lend itself to gaining weight as well, because again, it has to do with changes in hormone levels during the day. And again, if your child's not getting good sleep, whether it's due to sleep apnea or just poor sleep habits, they're certainly at risk of gaining weight as well.
That's a very important point. Thank you. I want to ask, what about bedwetting?
Yeah, so again, we see plenty of patients in our sleep center with bedwetting. Fancy term is nocturnal enuresis. And quite surprising to lots of parents as well as kids, the upper limit of normal, quote unquote, for kids to still have that concern can be up to 7 years old. So if I see a kid that's 6 or close to 7 with still that issue, I try to tell the parents that it's still normal. But again, lots of parents, especially once they have control of their bladder during the day, certainly want that at night. And bedwetting, as you could imagine, is related to potentially sleep disorder breathing or obstructive sleep apnea. So we certainly want to rule out sleep apnea in patients at a bedwetting, especially when they're over 7 years old.
Dr. Judy, I have a question about surgery. It's a common question with parents. Are they taking out the tonsils or are they shaving it? What's the difference?
That's a very good question. So traditionally, we perform tonsillectomy and adenoidectomy. Adenoidectomy is just removal of the adenoids, which are a tissue up behind the nose, with using a technique which involves cautery as well as suctioning. But the question now people are asking regarding tonsillectomy, which is actual removal of the tonsil tissue en bloc or en masse, versus tonsillotomy, which is removal of the bulk of the tissue, or the shaving, as you put it. There's pluses and minuses for both. The pluses are, in the short term, favor tonsillotomy. There seems to be less pain, studies are showing, a smaller chance of the post-operative bleeding in the first 2 weeks after surgery, and better patient satisfaction. But the issue is that when you leave some tissue behind, in the case of tonsillotomy, there is the concern about tonsils regrowing. And what does that look like in the medium to long term? There are some concerns in the literature that this can be associated with recurrence of sleep apnea due to total regrowth of the tissue, but also things like tonsillitis later on in life in the tonsil remnant, which can facilitate a second surgery, which can be quite difficult because a place that has been operated on before can be quite scarred down, and reoperation on this site can actually be associated with more complications. So yes, tonsillectomy and tonsillotomy are both being performed. Tonsillotomy is something that is becoming more en vogue, but we just need more evidence to really solidify it as the long-term solution to the issue. We offer both here at Stony Brook, but it depends on the patient selection and what the needs of the patient are.
Thank you.
You're welcome.
Dr. Doody, when do you ask the patients to return to us after surgery?
Yeah, so the recovery from surgery, as I said, is 2 weeks at home. I see them back in clinic about 6 weeks post-operatively. If the child had a severe obstructive sleep apnea and they require follow-up in that regard, you have to wait at least 3 months before reattempting a sleep study to see what the residual breathing is like. Children with milder sleep apneas that report symptom improvement, I don't tend to follow up with them because they came to me with snoring. It was proven to be sleep apnea, and if they don't have the symptoms anymore, it's very safe to say that they're doing well. But certainly the children with severe obstructive sleep apnea, they need a repeat sleep study, usually at least 12 weeks post-operatively.
Yeah, it's so fascinating with in just these few minutes, we're able to kind of give information to parents about sleep. So what I would want to do before we end is just get key messages from each of you as far as this topic.
Sure. So I guess I'll go first.
Yeah.
Snoring is not normal. That's the first off. Again, snoring may be snoring by itself, or snoring may be a symptom of sleep apnea or other type of sleep-related breathing disorder. So I certainly encourage parents, if they notice their kid snoring, to either talk to their pediatrician or call the sleep center directly. And especially in young, developing kids where they're not just maturing physically and mentally, but improving in brain development as well, sleep is very important. And we want to ensure the most optimal sleep these kids can get to, like I said, make sure they're doing as well as they can in school, make sure their overall health is as good as it can be.
Dr. Judy?
Yeah. I think that children with obstructive sleep apnea, adenotonsillar surgery, it's not the be-all and end-all, but in the correct patients, in the correctly stratified and identified patients, it can actually cure a lot of children with obstructive sleep apnea and can be massively beneficial. The surgery is safe surgery. It's not without its complications because it's surgery. But at the end of the day, we cure a lot of children that have these issues by just one procedure. And it's very encouraging for parents and for myself to keep performing these procedures on these children and to get the results that we get.
Yeah. That's so fantastic. Thank you so much, Dr. Doody, Dr. Ednick.
Yes.
So I think that's all the time we have today. And thank you to our experts for your time and expertise. And thank you to our viewers and listeners for tuning in. And if you found this conversation interesting, don't forget to like and subscribe for more informative health-related content. Thank you.
Stony Brook Medicine is Long Island's premier academic medical center. We transform lives through scientific discovery, education, and care, and we bring together innovative research, advanced education, and extraordinary healthcare expertise to set the standard for how healthy communities thrive. For more information, visit stonybrookmedicine.edu or follow us on social media. Stony Brook Medicine on Instagram, Threads, Facebook, YouTube, and LinkedIn, and Stony Brook Med on X.